Hi, I'm Dr. Joe Jabre. I'm a neurologist and I specialize in EMG. EMG stands for electromyography, which loosely translated means electrical testing of nerves and muscles. The nerve is like an electrical wire. So basically the way we test it is the same way an electrician tests an electrical wire. We run electricity through it. When the electricity goes through the nerve, we can see if it's getting stuck somewhere, if it's slowed, if it's not working at all, and so forth and so on. And basically we can determine where it's stuck or where it's slowed, how badly it is, and so forth and so on. Now when we stimulate the nerve, we can record either from the nerve directly or from the muscle that's innervated by the nerve. Why is that? Because the nerve contains, most nerves contain both sensory and motor fibers. Needless to say, the sensory fibers are the ones that bring the sensation from the fingers or the skin or the leg back to the brain. The motor fibers are bringing the brain signal down to the muscle to move it. So whenever you're stimulating a nerve, most of the time you're stimulating both nerves that are sensories and nerves that are motors. It really depends on where you are recording from. So for instance, if we are recording from the finger and we're stimulating the median nerve here, but recording from the finger, we're recording from the sensory fibers. If we stimulate the nerve and we record from the muscle, we're recording from the motor fibers. So it really doesn't matter where you stimulate. Actually, it does. But what matters most is where you record from, because that's what it's going to determine if you're studying sensory or motor fibers. Now, what are EMGs useful for? EMGs are useful for a lot of conditions and a variety of problems that affect the nervous system. The ones that you've probably heard most about is carpal tunnel. A lot of people have carpal tunnel with hand numbness and tingling and sometimes weakness, patients with low back pain, patients with diabetes who get diabetic neuropathy. For all of these conditions and others like trauma and injury and neck pain, a lot of physicians order nerve conduction studies and EMG testing because they want to see if the nerve is impaired, is damaged, how bad, and where it is impaired. So in order to do the study, we use an EMG machine. And here you have an EMG machine that sits next to a laptop. The laptop really has the programs that run the EMG machine, but the EMG machine feeds the signals that we get from the patient or the subject into the laptop, and the laptop analyzes those. Let's talk now a little bit about the needle electrode. This is the needle EMG part of the study. So for most exams, we do nerve conductions and needle exams. Now, some exams you probably will get away by doing nerve conductions alone. For instance, carpal tunnel. If it's not severe, just by demonstrating that there's slowing across the carpal tunnel, you have your answer. Peripheral neuropathy, rather acute onset low back pain, to see if there's changes in H reflex. But sometimes you need to do further studies and you need to explore other muscles that you have not studied with the nerve conductions, so you need to do a needle exam. Let's start by the needles that we use. Right away I will tell you there's different types of electrodes, needle electrodes. Some are called concentric, which really means there is a shaft, there's a cover, and there's a wire inside the shaft. So it has really two electrodes inside that needle, essentially. And this is almost the same as when you have the nerve conductions. You have a black and a red. Think of it as the two electrodes, one black, one red, which immediately brings me to the point that if you have one black and one red, you actually also need a green, which is the ground electrode, which I'll be talking about in a minute. So for the needle electrode, you have the concentric needle electrode, and you have another type of needle electrode, which is called the monopolar. Now the concentric or the monopolar are perfectly good to use. The concentric has two electrodes, as I said, but the monopolar has just one electrode. And so whenever you're using a monopolar, instead of just using a green electrode, you have to use the monopolar, a red electrode, and a green electrode, because always you have to have three. I'm going to be demonstrating what we do with the needle exam with the concentric electrode, because that's the one that I use, and I don't have to place a red electrode and a green electrode. I can get away by just using the needle and placing one electrode only. Now, for the needle exam, we do certain muscles in the upper extremity and in the neck, certain muscles in the lower extremity and in the low back. The set of muscles that I study routinely in the arm is the first dorsal interosseous muscle. Bring your finger up like so. No, this one here. And this is the muscle between the index and the thumb. Okay, I study the flexor carpi radialis muscle. By the way, this is an ulnar innervated muscle, C8T1 levels. I study the flexor carpi radialis muscle, which is a median innervated muscle, more likely C6 and 7. I study the brachyradialis muscle, the triceps, and the deltoid. Then I do the paraspinals in the neck. In the leg, as a routine, I study the extensor digitorum brevis muscle, the tibialis anterior muscle, the medial gastroc muscle, the vastus lateralis, and the lumbosacral paraspinals. I'm going to go over each one of these and describe them to you in details. But this is, I just wanted to give you first the list of the routine muscles that I study in the upper and lower extremities. So how do we study the muscle? Well, the muscle moves, so we study it with movement. But we also studying the muscle when it's still. That means when it's not moving. The reason we do this is because whenever a muscle loses its nerve supply, it begins to contract spontaneously. This spontaneous contraction is called fibrillation in positive waves. That's a wonderful early indication of loss of nerve supply to the muscle. So the first thing that we do when you stick the needle in the muscle, we want to look for these muscle fibers that lost their nerve supply. So we insert the needle in different places to find out if the muscle is showing signs of denervation, loss of nerve supply, and emitting electrical activity that are fibrillation and positive waves. So the first thing that we study with the muscle is the muscle at rest with doing insertional activity. That means the muscle is not moving, we're just inserting the needle. The second part of the study of that muscle is to ask the subject to slightly contract the muscle so that we look at the motor units. When a subject activates the muscle, the motor unit starts contracting. You'll see it firing on the screen, boom, 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 boom. If you ask the subject to increase the activation, to increase strength, then you have more than one motor unit, 2 or 3. If you increase the effort further, you have 5 or 6 or 7. Sometimes you have 10 or 12. And that's called full activation. That means the muscle is fully activated and all the motor units in it are activated. So we study the muscle during activation at 3 level, mild effort. And I will show you that with mild effort, you only see few motor units, therefore you can study them very nicely. We study them at moderate effort. That means you study the muscle when it's more activated at maybe 30 or 40% activation. You still can see independent motor units, individual motor units, but you can't analyze them as nicely and easily. And then we want to see if all the motor units can get recruited when the subject puts full strength. And now we ask the subject to put as full of an effort as possible just to see if they have enough motor units or not. And once we've done that, we move to the next muscle. We do exactly the same thing. Insertional activity in different areas. Because, you know, you might be over a muscle fiber that's still innervated. You want to see if you can get close to a muscle fiber that lost its nerve supply. We sample the muscle insertional activity in different areas. Then we go to mild effort, moderate effort, and full effort. When we're done with that, we go to the next muscle, next muscle, next muscle. The reason we do a combination of muscles, I'm going to give you an example. For instance, if we study the first dorsal interosseous, which is an ulnar innervated muscle coming from the C8 and T1 roots, that's the ulnar innervated muscle that may be normal or abnormal. Let's say it's abnormal. Then I would study the abductor pollicis brevis muscle. Now that's a median innervated muscle, also coming from C8 and T1. If they are both abnormal, the patient either has a median nerve problem and an ulnar nerve problem. Or, more likely, they have a C8T1 root lesion at the back, in the back of the neck. So basically, what I'm trying to do here is study muscles that come from different nerves, but from the same place in the neck, or from the same nerve and different places in the neck. For instance, if you have a median nerve lesion at the elbow here, okay, I study the flexor carpi radialis muscle, which is a median innervated muscle, but coming from C6-7. And then I study the APB, which is also a median innervated muscle, but coming from C8-T1. So if this and this are affected, that means that it could be a C6-7 and a C7-8 and a C8-T1 root lesion, multiple levels, or it could be a median nerve. More likely than not, it's a median nerve. So the idea behind selecting what muscles to study is to choose the ones that will show you whether it's a nerve lesion or a root lesion coming from the back of the neck or from the back of the back, from the low back essentially. And that's why I choose the muscle. For that reason, in the arm, I choose some ulnar muscles, some median muscles, some radial muscles here, because remember in the nerve conduction studies, we study median, ulnar, and radial. Then I study the triceps, which is radial innervated, and I study the deltoid, which is axillary innervated, C5-6. Now, if a patient is coming to you with a recent herniated disc, none of these things might show anything, but the patient might have a lot of symptoms. Under those circumstances, I study the neck muscles. The neck muscles are called the cervical paraspinals, and they will show early changes before we see changes in the extremity in the arm. And we study the low back paraspinals, they will see changes before we see changes in the leg. So now that we've talked about the needle exam and what we do and how we do it, we have our patient, who actually is a subject. Her name is Samantha Joy, and we already had done the nerve conduction studies on her, so now we're going to do the needle exam. Whenever we do the study, I'm going to show you how we start doing it here. We launch the program on the machine, and we're going to input her information, saying new, and I'm going to type her name. Here we go, Samantha. And she's a female. And what's your date of birth?
9/17.
9/17.
1987.
1987. Okay. And about how tall are you?
5'3".
5'3", and I have this table here that tells me that 5'3" is 160 centimeters. It's important because, you know, in this day and age, everything in centimeters, so you really have to have a table handy. 167. And then weight, you already told me it's about 50 kilos. Okay, department is neurology. And diagnosis, you can enter, for instance, say low back pain. Now, she may turn out to be completely normal. I certainly hope so, but I'm just entering a diagnosis. And here we choose a template. The templates, that means, you know, you can choose whatever muscles you want to study. But the template, I say, you know, normally I study this muscle, then this muscle, then this muscle, then this muscle in that order. So this way it saves me some time by pressing the next button on the EMG machine, and it goes to the next muscle that I normally study. I don't have to input the muscle name every time. So here I'm going to choose a template. I'm going to do the left upper extremity, the left arm. And here we go. I'm going to say the left arm EMG, and that's going to give me all the muscles that I normally study in the left arm to do an EMG. Okay, and the machine is activated now. You see the screen here. Let me show you what you see on the screen a little bit. So you see here it says if FDI left, that means first dorsal interosseous. That's the first dorsal interosseous on the left side. Okay, that's the muscle that I'm going to study first. And on the screen, you're going to see a rundown of when I do the insertional activity inside the muscle and when I do the activation of the muscle, you're going to see all these potentials. Now, the needle exam a little bit less quantitative than the nerve conductions. In other words, a great deal of the stuff that you have to do, you're going to have to eyeball. But it's easy also to measure the amplitude of the motor units and the number of phases that they have in them. And I'll tell you a little bit about the amplitude and the phases and the duration and what they mean in pathology. But basically, that's what this is going to show you. And when I accept it and analyze it, I'm going to determine whether it's normal or abnormal. So here we go. First of all, I want to show you that I have an alcohol swab and a dry gauze here. And before we get started, I want to put the electrode, I want to put it out of the way. I'll put it right here. You know, that's the ground electrode. I'm going to put it out of the way. Here we go. And then I'll put this needle electrode here, like so. And I will put the plug in the electrode. Okay, input place for the machine. Here we go. All right, and now I have the black and the red here inside that plug. You don't see it, but take my word for it. And then the green here. So there are two electrodes in this because this is a concentric, and a green ground electrode, which we use as a separate electrode. And then the first thing I'm going to do is I'm going to wipe her finger with alcohol. And what I like to do is wipe the areas that I'm going to study, so that if I ever forget to wipe it, I've already wiped it. To be honest with you, I don't think this does anything, this alcohol. I think it makes the doctor feel better. But at any rate, it might also make the patient feel better. Now, what am I missing in doing this? Never do a needle exam without gloves. Two reasons. One is you're going to stick the patient. You might hit a blood vessel, and if the patient has something that you don't want to get, it's best to protect yourself. The second reason, if you stick yourself, now the patient might get something from you that you don't want them to get, and more importantly, that they don't want to get from you. So it's a two-way street protection, so always use gloves. So let's go for the first muscle, the first dorsal interosseous muscle, which is really the muscle that lifts this index finger up. Lift the index finger up, point it to the ceiling. It bumps up here, okay? So right now, put your finger down, relax. And I'm going to put this out of the way. And I'm going to go inside the muscle. By the way, I just want to show you, that's the size of needle that I normally use. It's 37 millimeter, 26 gauge. And I like this because it's not likely to bend inside the muscle. It's not skinny enough so that it bends. I've never had a needle break, by the way, inside the muscle. And it's firm that you can explore the muscle and not really have the needle be in the way and hurt the patient too much. It's best to have a firm needle to study the muscle, because if you're studying big muscles, you want to make sure that it doesn't bend inside. So here we go. You're going to feel a stick here. By the way, the stick hurts only when it penetrates the skin. Once inside the muscle, it's going to feel like pressure. The painful part is when the needle penetrates the skin. Here we go. 1, 2, 3. That's it. And I'm inside the muscle now. Now I'm going to see the activity. So I'm turning this on here. Okay. And you see that the muscle is not moving. Okay, so we have a flat line. So now I'm going to do now I want to show you that we are in the muscle. Raise this finger up gently. Gently. Raise it up. Keep it up. You see, now I'm inside the muscle. These are motor units. Okay. But I don't want to just show you motor units. I just want to show you that I'm inside the muscle. So now I'm going to do the insertion activity. And I'd like you to focus here first. Okay. Here. Insertion. 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 Insertion, insertion, insertion. Okay, so I'm exploring the muscle insertion activity in different directions to make sure that I'm not missing any muscle fibers that lost the nerve supply. Now I want you to watch the screen to see when I do the insertion what it looks like. Here we go. Insertion, you feel this, and then it stops. You feel insertion, the muscle reacts, then it stops. It has to stop completely when you stop the insertion. If it does not stop, it might mean one of two things. Either you have hit the area where the nerve enters the muscle, and that's spontaneous activity, which is called end plate potentials, and these are perfectly normal, but they will hurt the patient. It will be painful. The patient will let you know. And then when you move the needle a little bit up or down away, maybe 1 or 2 millimeters, not too much, you will get away from that area, and the patient will be okay afterwards. Now I want you to and the second thing that it could be fibrillation and positive waves. Fibrillation and positive waves are seen where the muscle is denervated. Here we go. Now stop. Okay. Now raise your finger up to the ceiling. Now these are the motor units. They are normal motor units. The muscle is firing normally. And this is at moderate activation. Raise it a bit less, a bit less. Now I see 1 or 2 here, 3. Raise it some more. Raise it some more. Okay. And now raise it up all the way. And now this is called full interference pattern. That means that the muscle is fully activated. So that was the first dorsal interosseous muscle. Now we're going to do the flexor carpi radialis muscle. Again, as I said, the flexor carpi radialis muscle is a median innervated muscle, and it's right here. The way I activate it, I ask the subject to pull their arm up all the way and bend your wrist, bend your wrist towards you, and the muscle bumps up like here. Okay, now relax, and then I put the needle inside here. 1, 2, 3, that's it, and I activate it. Here we go. Again, if you watch here, insertional activity. And it stops perfectly nicely right after I stop. Okay, that means it's normal. Then I do the activation. Raise your wrist up gently. Here we go. Some more. These are normal motor units. They have the normal size, the normal duration, the normal amplitude. Later on in this presentation, I will show you these individual motor units separately, show you how to measure them, and show you what they look like when they're abnormal. Now pull it up all the way. Perfect. This is perfectly normal. So again, insertional activity in several directions. I see activation on the screen. Whenever I stop the insertion, the potentials go away. They don't persist. And then I ask the subject to have mild activation, moderate activation, and full effort. Relax now. I'm going to take the needle out. Here we go. Needle out. The next muscle that we're going to study is the brachioradialis muscle. Brachioradialis is here. It's a radial innervated muscle, primarily C5-6. Let me show you how to activate it. You ask the subject to point the thumb up to the ceiling and raise your arm up. Raise it up all the way. Raise your arm. See how it bumps up here? That's where the brachioradialis is. Now put it down. Okay, and I'm going to press next, and that's going to take me to the brachioradialis muscle. Here we go. I insert the needle. 1, 2, 3. That's it. Okay. And I start. And again, insertion. Oops, some artifact. Here we go. Relax. No, relax. I want to emphasize that when she's relaxed, we see zero activity. When I insert, if you look at the screen, you see activity from the muscle. Insert, stop, insert, stop, insert, stop, insert, stop. Right? Insert, stop. Now I've looked at different areas of the muscle and I don't find any abnormality, so I'm going to ask her to raise the arm just gently. And here you see motor units. Here we go. Raise up some more. You see more motor units all the way. And these motor units look perfectly normal. They're what we call mono or biphasic motor units. That means they do not indicate re-innervation, and that means the muscle is fully innervated. Now relax. Here we go. I take it out. The next muscle is the triceps. It's a radial innervated muscle. It has some C6, C7, and C8 in it, actually. Very useful muscle because in C6, 7 root lesions, you might have an absent triceps jerk. So I get the triceps right here. Push down on my hand with your arm, and the triceps hardens up here. Here we go. 1, 2, 3. Stick. And that's the triceps. Now let's look at the... Oh, oops, we got a lot of artifact here. So probably the problem is that we have to put the ground electrode closer to it. Here we go. And let's see if that fixed it. Well, we're still getting a lot of artifact here. Let's see. Here we go. We got away from that. Artifact, unfortunately, is something that you're going to have to deal with on a daily basis. You move the ground electrode, you turn some lights off. But if you're inside the muscle and you have a good ground electrode, you probably will avoid those. But it's something that you're going to encounter in your daily life. So here we go. I do insertion activity. Relax, relax, relax. Relax. Now she's not relaxed. And again, you always do EMGs with 2 hands. So with one hand you try to relax the muscle, with the other hand you try to move the needle. Here we go. Insertional activity. Here we go. Here we go. Here we go. Notice how it comes up and then it stops completely when I stop. Here it's not, because she's still activating the muscle. She's not doing it on purpose. That's just she's not able to relax it completely. Here we go. Occasionally I get it relaxed. Push down on my hand. And here are the motor units. This is moderate activation. I'm looking at different motor units. Push up against my hand all the way, all the way. And this is full activation. So now the muscle is fully activated and it's perfectly normal. Now I'll take it out. Well, the last muscle in the upper extremity is the deltoid. I'm not including the paraspinals yet, but the last muscle in the upper extremity is the deltoid. The deltoid is right here. It's innervated by the axillary nerve, and it's C5-6 innervated. Here we go. Stick. That's it. And let's see this here. Oops, a lot of artifact again. Here. As soon as I get inside the muscle, if I'm outside the muscle, I'm going to have the artifact. As soon as I get inside, I get rid of the artifact. Here we go. Insertional activity. Insertion. Insertion. Insertion, insertion, insertion. I get activity and it stops perfectly still after that. If it continues, I'm either in the area where the nerve enters the muscle, or it's pathology, fibrillation, and positive waves. Obviously, you have other potentials that I'll talk about later on, and that will include fasciculation, myotonic discharges, chronic repetitive discharges, or cramps, and so forth and so on. But I'll show you this in the pathological section. Push against my hand. And that's how you activate the deltoid, with your elbow. And you see the motor units here. Push all the way. And the muscle is fully activated and it's perfectly normal. So that's the deltoid. Here we go, I'm taking it out. And now we're going to do the cervical paraspinals. I've wiped it out with alcohol already. And again, those are not easy to relax. So I have the subject hang their head over the pillow, essentially. And I'm doing the left paraspinals. The way you localize those is look for the C7 spinous process. That's the most protruding bone up here in the neck. That's C7. And one level above that is C6, one level below that is C8, and then T1. So first I go to C7 because I want to make sure I get this one first. It's going to be a needle stick here, 1, 2, 3. Here we go. Okay, now relax. Put your head above, put your head over the pillow. Here we go. And again, she's very nice and fully relaxed. And I'm in C7. Here we go, relax a little bit. I mean, insertion activity is perfectly normal here. I don't need to activate it. Okay. C8, here we go, 1, 2, 3. Relax, put your head down. Perfectly normal insertional activity. And then I do C6 here, one level above. And again, perfectly normal insertional activity. So now we're going to do the lower extremity needle exam. In the lower extremity, we do several muscles. First is the extensor digitorum brevis muscle, which is this muscle here that when you point your toes towards your nose, it bumps up. Relax your toes. Point them up again. See the muscle pumping up? Okay, relax. That's a peroneal innervated muscle, L5S1. Then we do the tibialis anterior. That's another peroneal innervated muscle, but it's in the L4-5 distribution. And then we do the medial gastroc, which is a tibial innervated muscle, primarily S1 and S2. So now here again is where we're going with trying to find out different muscles, different nerves, same root level, different root levels, same nerve. For instance, if you have a peroneal nerve lesion, the EDB and the tibialis anterior will be involved, okay? And because it's a peroneal nerve lesion, even though this is L4 primarily. This is L5 and S1. So it could either be a peroneal nerve lesion or L4, L5, S1, which is less likely. However, if you have this involved, the EDB involved, and the medial gastrocnemius muscle involved, it's more likely than not it's a root lesion. That means because this one has S1 and this one has S1, it's more likely than not to be an S1 root lesion or a peroneal and tibial muscle, which is sciatic, but it's less likely. But this is how we troubleshoot that. Now, because these are L4, L5, and S1, we need to do a thigh muscle, which is an L3 muscle, and we do the lumbosacral paraspinal. So let's start with the extensor digitorum brevis muscle. And again here, what you do is you point your toes up and relax. Now I see the muscle, and we're going to put the needle inside of this. Here you go, 1, 2, 3, that's it. And now we're going to do this. Relax, relax, relax. Here we go. Insertional activity. Again, stops completely as soon as I stop the insertion. And then I ask her to activate the muscle, bend the toes up, bend them just gently, gently, even less. You see nice motor unit potentials here. Maybe 2 or 3 units, maybe 4. Okay, now bring your toes up further, all the way up, 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 up. That's good. Now you see a very nice interference pattern in which we see all of the units that are activated. And they look perfectly normal. They're nice size. They fill the screen, and they are fairly narrow. So they're mono or biphasic motor unit potentials, and they look very normal. The next muscle we do is the tibialis anterior, which is right here. This is the tibia. I do it about 2 finger breadths lateral to the tibia, right here. I'm going to stick it like so. Now notice I'm sticking the needle about at a 45-degree angle. The reason I do that is because when you move the muscle like so, the needle is going to become parallel to the muscle fibers, essentially. And so it hurts less than if you're putting it perpendicular. So here we go. We're inside the muscle. We're going to see the activity. Here we go. Insertional, 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 and it stops. I take it out a little bit. Now I've seen the insertional activity. It looks normal. Now I'm going to ask her to point your toes towards your nose. And again, I see the motor units. And I can study them, and they look okay. Now point your toes even further up, all the way, all the way. Here we go. And she's filling the screen. So that's full activation. Now relax. And that was the tibialis anterior muscle. The needle is out. The next muscle we're going to study is the medial gastrocnemius. This is a tibial innervated S1, S2 muscle. It's right here. It's a calf muscle. And here I stick the needle like so. 1, 2, 3. That's it. And I'm going to do insertional activity. Again, it stops as soon as I stop the insertion. Then I activate the muscle. Push down as though you're pressing on the gas pedal. All the way. And that's muscle activation. Here we go. And it's filling the screen. And the units look normal. And again, I'm going to cover how you determine that it's normal, how you measure the amplitude, how you measure the duration. I'm going to show you what it looks like when it becomes abnormal. One thing I always recommend to my students and residents is whenever you're doing studies, get yourself used to listening to the sound of the motor unit to recognize the normal just by sound versus abnormal. Push down on my hand. And this is a very, very normal sound. The abnormal motor unit sound will be thumping. And it will be very, very loud, like a motorcycle idling. And we're done with the medial gas muscle in the leg. Is going to be the vastus lateralis, part of the quadriceps. And here we insert it right here, stick. Okay. And let's see it again. Again, insertional activity. Here we go. Insertion, and it stops. Insertion, 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 and it stops. And that was the insertional activity. Now, let's see the activation. Press with your knee down on the bed. Some more, some more, some more. And this is the sound of normal. They're normal motor units. Push down some more. They're filling the screen. And I don't see any polyphasic potentials. They look perfectly normal. And now we're done with the vastus lateralis. Okay, and now we're going to do the lumbosacral paraspinals. And that's, as I indicated before, they're very, very useful in early root lesions, because in early root lesions, they are the first one to get denervated. And you might find problems here that you're not going to find in the leg. If the patient has had symptoms for 2 or 3 months, I would forego the paraspinals because they might not show anything. So I'm going to put the ground here. For the paraspinals, I'm going to do the same levels as I did in the leg. Namely, I'm going to do the L3 paraspinals, the L3, L4, L4, L5, and L5S1. Now, how do I localize those? It's easy. You go for the iliac crest, which is right here, okay, and you draw a line from the iliac crest to the vertebrae here, and that's the L4 vertebral body. I go 1 finger breadth lateral to that, and that's where the paraspinal is. So iliac crest, okay, the hip bone here, draw a line to the vertebral spinous process, that's L4, go 1 finger breadth lateral, and that is where the L4 paraspinal is. So I stick this here like so, okay, and sometimes these muscles are tough to relax because the patient is not seeing what you're doing to them, and they're not, but sometimes, so what I do is I lay the patient, I lay the patient on their belly with a pillow under the belly, and that's the best way to relax them. In the paraspinals, I just insert the needle just to see if there's insertional activity, fibrillation, and positive waves. Here we go, relax, relax, okay. And take this pillow off here for a minute, okay, and put your head down. Okay, now here she's fully relaxed. Another one. Perfectly normal insertional activity, and I see no fibs and positive waves, and she is fully relaxed, and that's the L4. Then I do the L3 above it. Here we go. Stick. Relax. Excellent. That's the L3 paraspinal. Now let me show you here. Again. Normal insertional activity. When I stop, it stops. And obviously, sometimes it's not easy to relax, but now it completely stopped. So that was L4. 2 finger breadths above is L3. 2 finger breadths below is L5. It's going to be a stick here. That's it. Relax. That's L5. Here we go. That's L5, and that's normal. And then 2 finger breadth below that, that's S1. 1, 2, 3. Relax. You need both hands to make sure the subject relaxes. Again, insertion activity, and absolutely no abnormal insertional activity, no fibrillation and positive waves. And I'm done with the lumbosacral paraspinals. Now let's talk about needle EMG potentials. The first ones what we're going to talk about are the normal activities that we will see with inserting the needle in the muscle. First with the muscle at rest, then when we're activating the muscle. When the muscle is at rest, we look at the insertional activity. This is a normal activity that is seen when we insert the needle in the muscle, as you see, and you see some spikes reaction, and they immediately stop after the needle is still. That's normal. However, if you're inside the end plate area of the muscle, that means where the nerve enters the muscle, the insertional activity persists like what you see now. That is a normal insertional activity in the end plate zone. By the way, this is a painful area. You must stop when you reach it and pull out or insert the needle further. Now when we activate the muscle, we see motor unit potential. This is a single motor unit potential. Obviously the muscle is being activated at mild effort at that level. And we can fully analyze this unit potential because we can see the duration, the amplitude, and the number of phases, and so forth and so on. However, when the muscle activity is increased during moderate or full effort, we'll start seeing more and more unit potentials, as you can see here. Now we see 2 or 3. We still are able to analyze those, but not as well as with a single unit. And you can see that at the end of that, when the patient stops activating the muscle, the unit completely ceases. And now we ask the patient to do full activity. And during full activity, there's many more units, 4, 5, 6, or 7 sometimes. And you see that the screen becomes more full, and it may be more difficult to examine at that stage. Now here's an example of muscle cramps. The muscle is completely still here, and you see activity of filling the screen, and the patient is not moving. This is a cramp. It's very painful. Stop what you're doing, stretch the muscle, wait a few minutes, and then proceed. Another activity now that we're going to see is going to be abnormal. These activities can be seen during insertion or during activation of the muscle. The first one that you hear of most is fibrillation and positive waves. This is when the muscle is completely still, the needle is inserted, and now you see these potentials, usually from single fiber potentials that come, some of them downgoing, some of them upgoing. These are called fibs and positive wave. The muscle is completely still at this point, and that's a very nice picture of the positive waves. That means that the muscle is denervated. When the muscle has been denervated for a long time, you see complex repetitive discharges. Again, the muscle is still here, and you have continuous discharges like this. That means the muscle has been denervated for a very long time. You see that in chronic low back and neck pain. Some activities that are abnormal at rest also are the notoriously well-known fasciculations. That means it's a whole motor unit now that's activated, and it's activated when the muscle is at rest. Obviously, the term fasciculation is associated with ALS, but sometimes they can be benign fasciculations. But this is the activation of a whole motor unit when the muscle is at rest. And they come and go, and they usually are slow in their firing rate. Another activity is myotonia. These are the famous dive bomber discharges. These are seen in patients with myotonic dystrophy and myotonia congenita. And you can hear the noise that they make. This is, by the way, during insertional activity. The muscle is at rest. And then you can hear the dive bomber typical responses. You'll see those in a minute. This is the normal motor unit that you see during this discharge as well. But the patient is barely activating at this point. And here we go. You see the dive bomber type discharges. They're very easy to recognize, and they're usually present in myotonia. In chronic denervation, when the muscle has lost its nerve supply and then it got reinnervated, you see these polyphasic units. You see the unit has many phases, and occasionally you have these big large units that come in as well. This is chronic denervation and reinnervation, and is seen when the lesion has been there for at least 4 to 6 months. When the lesion has been there for far longer than this, years, you will see a long duration unit, occasionally with satellite potentials, and these are seen in very chronic, long-standing denervation. Muscle disease or myopathy usually will show small polyphasic units that are very narrow and scratchy. They sound like hail on the tin roof, and this is typical of myopathies. Usually they're activated very quickly. So now we're done with the needle exam, and we looked at the upper and lower extremities and the paraspinals, and we use muscles that will show changes with the most commonly encountered conditions that come to the EMG lab. And what I want to remind you of is in the muscle we do 2 stages of investigations. The first one is the insertional activity, in which we're looking for fibrillation and positive waves, and whether or not there are spontaneous activities like fasciculations, and myotonic discharges or chronic repetitive discharges, etc. And then the second stage in the study of the muscle, we do activation to see if there are any abnormal units that could be neurogenic, that means caused by a nerve lesion, or myopathic, that means caused by muscle disease. Whenever you're getting most people would say, an acute lesion, it's best to wait about 21 days before you do the needle exam, because the needle exam may be normal in the beginning, and you're going to have to bring the subject for a second time to do the needle exam, and they might not be too happy about it. In acute back or neck injuries, within the first 2-3 weeks, you probably will find problems in the paraspinals, but not in the leg or arm muscles. After 3 or 4 weeks, you're going to start having these findings in the leg or arm muscles, and they may disappear from the paraspinals. So again, a routine set of muscles in the upper extremity, routine set of muscles in the lower extremity, the cervical paraspinals, the lumbosacral paraspinals, and then the different stages of activation of the muscle. Thank you very much.